Well, John, thank you for that very kind introduction. It's really a pleasure to be back here and back at my undergraduate alma mater, and really, really nice to be here. Now, all right. Oops. Okay. So I wanted to talk about some work we've done in an area that we've gotten really interested in over the years, and John alluded to some of this. And the fact that some of this has Utah roots, and I'll talk about that. Anne played a critical role in all of this. These are my disclosures. None of these are actually relevant to this presentation, but this is what they are. These are the learning objectives for the talk, and so these are that to describe the concept of immune dysregulation in the broader context of immune deficiency disorders. This will make sense in a couple of minutes. Describe 2 to 3 genetic disorders associated with early onset autoimmunity in patients, and then explain specific diagnostic and treatment approaches that can be employed to diagnose and treat patients with immune dysregulation disorders. And so it will, hopefully this will make sense by the end of the talk, and you'll be able to answer these 3 things. So this is the outline for the talk. So I want to give some general background, and then I'm going to give we're going to talk about some specific disorders. I'm going to start with IPEX, which is the one of the disorders that Harry alluded to, that John alluded to, that we will talk about, and then some other disorders that are like IPEX, and we'll talk about those, and then talk about treatment. So I want to start first with just with the introduction to this field of immune deficiency and sort of where we are, and I think it's worthwhile to just review this. I think just for those of you who haven't studied immunology a lot, I think this, some of the really interesting parts of immunology really began back in 1956 with this paper. And I always tell the graduate students, everybody, all the graduate students, they want to publish in Cell, Science, Nature, all that. And I always tell them, one of the most seminal papers in all of immunology was published in Poultry Science. So just get published. That was the recognition that, in fact, B cells that make antibodies develop in the bursa of Fabricius in chickens. And subsequent to that, actually the year I was born, 1966, Max Cooper, who's still active and an active investigator, Max and colleagues described these 2 groups of lymphocytes. There was a group of lymphocytes that made antibodies that developed in the bursa of Fabricius. They were called then B cells, bursa cells, and there were cells that developed in the thymus of the chickens that were called T cells or thymus cells. So B cells and T cells were named, and that's where that comes from. That was in 1966. And then in 1972, the first molecular defect in an immunodeficiency was described. And this was described enzymatically by Elo Giblet, who was actually a hematopathologist, a hematologist in Seattle, who identified adenosine deaminase deficiency in patients with severe combined immune deficiency. It was, again, identified enzymatically. She then went on to identify PNP deficiency, also identified enzymatically. And then in 1973, one of the textbooks that we use in clinic for clinical immunology, the STEAM textbook, the first edition came out in 1973. So you see sort of where this was placed and its size. Now, in 1975, then the differentiation between CD4 T cells and CD8 T cells was made. It's not that long ago that this happened, and so that's when this was published. And then here's the 3rd edition of the STEAM textbook. It's growing now in size with increasing knowledge. And then really the genetic revolution began within the immunodeficiency world in 1993 with the publication of a couple of the first genetic defects identified, which was BTK gene in X-linked A-gamma-globulinemia and the CD40 ligand gene in X-linked hyper-IgM syndrome. And now there's been an explosion. This was, of course, the 5th edition. You see now it's getting quite a bit larger in 2005. Now, the most recent version is on an iPad. It doesn't really sort of make it look quite as dramatic here. But now, as I'll show you, there's 344 genetically defined immune deficiency diseases that we can use that have really informed us a tremendous amount about the human immune system and what specific parts of the immune system do in patients. Now, this is the breakdown of those. Traditionally, when we talked about immune deficiencies, what we thought about were diseases in which patients had too many infections or recurrent infections, severe infections, and they might as patients with infections, as we got then antimicrobials and we were able to keep them alive for longer, we realized that some of these patients with infections might develop autoimmunity or autoinflammation, but the main features that people have traditionally thought about with immune deficiencies are infections. And so these are called primary immune deficiency disorders, PIDDs. And the IUIS committee, the International Union for Immunologic Societies subcommittee on primary immunodeficiencies, which I'm a member of, every few years we get together and we sort of catalog all of the immune deficiency genes, and the most recent publication just came out. It's 344 total genes, as I mentioned, and about 229 of these genes could be called primary immune deficiencies, where infections are the dominant part. But what's really emerged over the last about a decade to decade and a half is the fact that there are a number of disorders that are problems. They're genetic disorders, they're defects in the immune system, but they're defects more in the regulatory parts of the immune system. So the parts of the immune system that regulate the effector parts. And those patients present not so much with infections. Their primary presentation is more with autoimmunity or with autoinflammation. Now, they may get infections, but it's really the autoimmunity or immune-mediated pathology that is the dominant feature of these diseases. And so, for lack of a better term, we've recently been working on a grant and needed a name for this group of disorders. And Karen Chen's on this committee, and we've sort of coined the term primary immune regulatory disorders, or PIRDs, for these. So there's now PIDs and PIRDs, and together they make up these sort of the whole world of immune deficiency diseases, which is sort of like a universe. Now, among these PIRD disorders, I wanted to just sort of highlight sort of some of the different groups of these that have emerged as more and more genes have been identified. Now, the first group that made people sort of think about immune dysregulation, things like that, was this group of IPEX and IPEX-like diseases, which you're going to hear a lot more about through this talk. But there's a bunch of other things. So there's disorders that I would think of as kind of debris defects. So these are problems dealing with our own cellular debris. And when you can't deal with your own debris well, you make lots of type 1 interferons, and these are some of now called interferonopathies, and these patients develop lupus and Aicardi-Gutierrez sorts of syndromes. There's the congenital or familial hemophagocytosis disorders that are now quite a large group of genetic defects, so familial HLH syndromes. There's this group of autoinflammatory diseases that I know you guys see a lot of here. We were talking about these last night at dinner. These are the periodic fever disorders, and there's a growing group of these disorders that are considered as a group autoinflammatory disorders. There's this group of disorders that have been around for a long time where there is non-malignant lymphoproliferation, so they get big lymph nodes, big spleens, and this is the group of autoimmune lymphoproliferative syndromes. And then there's now a new group of disorders, really recently described in the last couple of years, where they're, for lack of a better term, we call them congenital hypersensitivity syndrome. So these are patients who have gene defects that make them just have terrible allergic type disease. And so they fall in this group of kind of immune dysregulation or immune regulatory disorders. I also lump in this group in the early onset inflammatory bowel diseases. So we know that in infant onset inflammatory bowel disease, depending on which cohort you look at, it's between 15 and 30% of those patients have a primary genetic defect that can be identified and treated. And then, of course, the very early onset and early onset IBD patients. And then I put in here rheumatologic disease because I am, after all, a rheumatologist by training, and my bias as sort of an immunogeneticist is that within this group of rheumatologic diseases that we see in the pediatric world, there are a lot of primary immunodeficiencies. It's just the defects are in the regulatory part, and we just haven't found them yet. And I predict that over the next several years, many of those genes will be identified, and we'll have hopefully 344 genes that cause a primary rheumatologic disease in children. So that's sort of this universe of immune regulatory disorders, and it gives you an idea of what the scope of these disorders are. So for the rest of the talk, though, I'm going to hone in on this group that we've called Treg-opathies, Tregs being regulatory T cells. And I'll come back to what those are and explain those in a moment. So just to give you an idea of how these PERD disorders are sort of how the field is really expanding and growing, this is where there's been a lot of growth in terms of identifying genetic defects. And this is looking at these PERD genes, really more than 50% of them, this is a subset of the genes that we're using in this grant proposal, more than 50% have been identified really in the last 5 years. And so things are really growing and expanding in this field, and I think this is an exciting area to be involved in. Now, you may say, why is this so important? Why is autoimmunity important in these immune deficiency disorders? And I want to just use this as an example. Now, this is these two graphs are from a couple of retrospective papers looking at one of the most common immune deficiencies that we see in clinical immunology. This is common variable immunodeficiency. We see this presenting in children, we see it presenting in adults, and among sort of in the whole spectrum of immunodeficiencies, this is one of the more common ones. And on the left is a paper that was published by Helen Chappell in her cohort from the UK, and this is from Charlotte Cunningham Rundle's group, and each of these groups is about 250 patients, somewhere in that neighborhood. And the bottom line here is that in patients who have common variable immunodeficiency and just get infections, as long as those infections are treated, they're on IVIG, they're on antibiotics, their long-term survival is no different, here and here in yellow, it's no different than the general population, okay? However, if those patients have immune dysregulation, meaning if they've got autoimmunity that affects the gut, the liver, the lungs particularly, this is their long-term survival. And in this case, in Charlotte's case, from diagnosis, 40-year survival is 40% essentially. It's terrible. So autoimmune disease or immune dysregulation is really the thing. It's not the infections that are killing these patients, it's the immune dysregulation. And that's why we think that this is such an important feature within the immune deficiency field. Why I think it is, at least, and I think that it's emerged as being recognized as that. All right, so let's talk about some specific disorders and some lessons that we learned. And this is sort of back to what John was saying. So this is that family that he mentioned that Anne had meticulously collected samples on, and there's also a second family that she had samples on. This, as you can see, is a very large family, and as you'll note, it's really the boys that are affected here. These patients were described in this report as having early onset enteropathy, so early onset diarrhea, watery diarrhea, early onset endocrinopathies, so it was type 1 diabetes and thyroid disease, thyroiditis, and early onset dermatitis, and it was usually eczema or sometimes other things. These patients also had other variable autoimmunity, but those three sort of things were most consistent among the boys that were described in this family, and most of the males that were affected in this family died before the age of 3. Some of them lived longer, but the majority of them died early. And as mentioned, Anne had collected this family, and in 1993 published in this abstract the linkage actually to the X chromosome, and it linked actually very close to the Wiskott-Aldrich syndrome gene as noted, and that's why it was thought to be maybe a variant of Wiskott-Aldrich syndrome. Now, this, they got very close to finding the gene. Unfortunately, the linkage analysis actually wasn't published until about until around 2000 it was published, and the gene was identified actually by a company in 2000, identified and published in 2001. And in that same issue of the journal in which the gene was described in the mouse, then there were two groups, including Hans's group in Seattle, Hans Ochs's group in Seattle, that described mutations in FOXP3 associated with this syndrome called IPEX syndrome. Now, to sort of give you an idea of what these patients look like, let me just use a clinical vignette. So this is one of our patients. He presented with watery, foul-smelling stool beginning shortly after birth. He had failure to thrive. He had dry skin and eczema by 2 weeks of age. And he presented in diabetic ketoacidosis at 8 weeks of age, was hospitalized in the ICU, and he also then developed cytopenias, autoimmune hemolytic anemia and immune thrombocytopenic purpura. He underwent a bone marrow transplant using a matched unrelated donor with a reduced intensity conditioning regimen, and he had a very complicated transplant course due to his diabetes being so brittle. And then his diarrhea just resolved shortly after conditioning, and about 14 months after his transplant, actually his insulin requirements went away, at least for a while. And he was able to actually come off insulin for a while. And he now is older. He just started kindergarten a year ago and is just is doing great. His diabetes is now, he's back on insulin, but on much lower doses than he was before. So we've now collected a large cohort of these patients. So we've had samples sent to us on probably close to 550 patients now, and we found 97 patients with mutations in the FOXP3 gene. So they have IPEX. So FOXP3 is the gene that causes this disease, and I'll talk about that more in a second. And among those patients, virtually all of them have the enteropathy or the bowel disease. They have, and some of the characteristics of that is villus atrophy on biopsy. They have failure to thrive, and a significant proportion, about a third of them, have really significant food allergies. They have, about 70% have endocrinopathies, as I mentioned. It's type 1 diabetes and thyroid disease, again, all autoimmune mediated. They have skin manifestations, eczema, alopecia, pemphigus nodularis. They've got a whole variety of skin manifestations. And almost 3/4 of them develop other autoimmune disorders. So cytopenias, kidney disease, liver disease, and pulmonary disease in some of these patients. So this is an overwhelming autoimmune disease that affects young boys, and I'll talk about why that's the case in a minute. Now, the reason that it is that these patients have mutations in the FOXP3 gene, and FOXP3 encodes a transcription factor that is required for the development of functional regulatory T cells. And so these are the regulatory T cells in a normal individual. If you take the CD4 positive T cells, which is what we've done here, and you look at cells that express FOXP3 and CD25, which are the regulatory T cells, they're here, and they comprise in a normal individual between 4 and 8% of their CD4 positive T cells. And here, in a patient with IPEX, with a severe form of the disease, you see they're essentially absent. And so really significant absence of regulatory T cells. So what are these regulatory T cells? Well, I tell my patients that these are really the psychologists of your immune military. So you've got a military that protects you against invasion by viruses and bacteria, and the regulatory T cells, really their job is to tell the other immune cells, you did a great job fighting off that infection that we had last week, but it's gone now, so settle down. Don't get so riled up. That's what go to the spleen, take a vacation. So this is what they do. So that's their job. And we know now several things about regulatory T cells. These cells, of course, require this FOXP3 transcription factor. They have a number of molecules on their cell surface, and they're able to express a number of proteins that are involved in their ability to regulate other immune cells. Now, the way that they regulate other immune cells, they can do this through a variety of mechanisms, and we actually probably don't know all of the mechanisms yet. But among the ones that we know about are their ability to regulate cells through direct cell-cell interactions, and using molecules like CTLA4. And I'm going to come back to this in a little bit, but this is a molecule that through direct cell-cell interactions is able to sort of turn down antigen-presenting cells and other cells within the immune system. They're also able to regulate the immune system through what we call bystander suppression, where they secrete cytokines that can distribute to nearby cells like interleukin 10, TGF-beta, that turn down the function of these other effector cells that surround them. Okay, so we'll come back to this in a minute. Now, we know that the lifespan of a what used to be called a natural regulatory T cell, now we are calling them thymically derived regulatory T cells, is that they're born in the thymus. And I'll show you that here in a second. So here's the thymus. Again, the thymus is like the university or the college where T cells go to be educated. And the T cells as they are developing, they enter the thymic cortex, they circulate through that, and they decide whether they want to become a CD4 or a CD8 T cell, and then they migrate into the thymic medulla, and it's really in the thymic medulla where we see the regulatory T cells showing up for the first time. This is a mouse thymus, and this is a picture from Sasha Rudensky. In blue here is the thymic cortex. In red is the thymic medulla, and the regulatory T cells are green in this picture. Okay, so you see that the regulatory T cells really are in the thymic medulla, and that's where they really show up for the first time, and they get turned on. This program of being a regulatory T cell gets turned on there in the thymus, and then those T cells leave the thymus and then are able to dominantly regulate other parts of the immune system out in the rest of the body. Now, of course, they leave the thymus, and here's the regulatory T cell. And in order to be fully functional, these regulatory T cells need to get activated. They need to expand and make more of themselves. And so that's here. We know that happens, and then they can suppress, and they can suppress using some of the mechanisms that I mentioned. Now, I'm going to come back to this figure later in the talk and overlay some of the genetic defects that I'm going to talk about to sort of show you sort of lessons that we've learned from studying some of these genetic defects, and I think that we have yet to learn. And so just keep this in mind. We will come back to this. Now, one of the things that's really remarkable that we've learned recently about this disease is that normally you think of the in utero environment as being a somewhat immunosuppressed environment because it allows a mother to carry a fetus that's only halfway matched to her from an MHC standpoint, only halfway matched to her, to carry that fetus to term and give birth to a baby, right? So there's very potent immune regulation that happens in that setting. However, if the infant does not have regulatory T cells, then they develop autoimmunity very early, and in fact, in utero. And this was shown. This is a patient that we had identified that we had identified his brother and transplanted him. Mom then became pregnant, and we prenatally diagnosed the baby as being affected. And there was late term problems, and the baby was delivered. The chest appeared to be very small, and they were worried might have a diaphragmatic hernia. That turned out not to be the case, and this work that I'll show you is by Eric Allensbach, who worked with me on this project. And this is what we found. This child was born and died at 29 hours of life of respiratory insufficiency. The child's lungs were only a third the size that they should have been. We actually don't know the mechanism, but we've now seen this in a handful of these patients. And what at autopsy what we found. So this is this infant. Again, 29 hours of life. Here's the pancreas. And you see, here's a normal pancreas from age-matched control over here. This is a sort of low res, higher res, and there is just lots of inflammatory infiltrate in this pancreas. And when you look at it in detail, you see there are T cells here surrounding these patches of B cells. So they're trying to form almost like a lymphoid follicle like we see in lymph nodes. And this is something that we see in the setting of chronic inflammation, which means that this has really gone on. This baby was term at birth. This has really gone on probably for at least a couple of months, this autoimmunity in this infant. And you can see it sort of here in more detail. And the other thing that we recognized about this is that what was interesting is that the infiltrates are primarily in the exocrine pancreas. They're not in the endocrine pancreas. And so now it's led us to believe that, in fact, part of the diabetes we see maybe in these patients is not, at least initially, not direct attack on the islets, but is in fact maybe just collateral damage from damage to the exocrine pancreas surrounding these. And we actually don't know what the target is there. We've recapitulated this in a mouse model of FOXP3 deficiency, and that mouse has a similar pattern, develops exocrine insufficiency first and then endocrine later. So, as I mentioned, we've collected a whole bunch of these patients, and about 20% of them have mutations in FOXP3. 20% of the patients that have this clinical phenotype that have been sent to us for analysis have FOXP3 mutations. So the rest of them, for lack of a better term, we've called them IPEX-like because they look like IPEX, but they don't have FOXP3 mutations. And so plowing through that population using approaches that that everybody's using now with next-gen sequencing and targeted sequencing, other things, we've now found mutations in these genes in about 35% of the IPEX-like patients. So together, between the FOXP3 mutants and the mutations we find in these genes, we can find genetic defects in about almost half of the patients that have now been referred. So that's the story. Now, I'm going to talk about some of these genetic defects in particular, but I want to just make this point that some of the genetic defects that I showed there have overlaps with other clinical syndromes and have been identified in other cohorts of patients. So for instance, STAT3 gain-of-function mutations and CTLA4 mutations have been identified in cohorts of ALPS patients. They've been identified in cohorts of CVID patients, and of course in our IPEX-like patients. And what it points to is the fact that there's certainly some overlap. These are, of course, the CVID patients with autoimmune disease, and there's some phenotypic overlap, but it highlights the point that genetics really are important in these diseases. I used to think that I was an okay diagnostician. Now I know that I'm a terrible diagnostician because I am not very able many times to predict what gene defect patients will have because the clinical spectrum of disease is so broad. And really, as I'll show you, there are tremendous advantages to finding a gene defect because it opens the way for directed therapies that may allow you to really dramatically impact the outcome of these diseases. And so I'll talk about that in a little bit more detail, but I do want to put in a plug, at least in these types of patients, for starting with the genetics very early in the course of disease and trying to understand what that is. Now, I'm going to show you a number of gene defects and how these fit in, but I just want to then go back to this figure of the life of a regulatory T cell and just highlight a few genetic defects that were on that list. So Apiced syndrome, this is caused by defects in the AIR gene that plays a role in thymic development of T cells, and these patients are also called, this disease goes by the name of autoimmune polyglandular syndrome type 1. This defect affects the ability of T cells to be selected appropriately in the thymus and in the ability of generating regulatory T cells there. Of course, FOXP3 gene, which is required for the development of the regulatory T cells. These two genes that are required for interleukin-2 signaling, and we know that this process that regulatory T cells undergo to expand and become mature requires IL-2 signaling, and so these are here. And then these gene defects, which I'm going to come back and talk about in just a second, that impact how regulatory T cells regulate other cells. So just now this taking what I'd shown you before, laying on top of it these genes and where we think they impact, and then I'm going to talk now about some of these other defects, and we'll come back to this in a minute. So I wanted to just talk briefly about management and about treatment of these patients. So these patients typically come very ill. And one of the things that we know from the mouse model of this disease, actually the scurfy mouse that John mentioned was actually derived in the 1950s at Oak Ridge National Laboratories, and it's been around for a long time. And through the years, through a number of studies that have happened, we know that if you take just the CD4 positive T cells from one of these scurfy or IPEX type mice, and you take just the CD4 positive T cells and you transfer those to a mouse that has no T cells, that mouse will develop the same clinical phenotype as that scurfy mouse, and it dies within about 3 weeks of this overwhelming autoimmune disease, which is what we see in these sort of IPEX mice. And so we know then from that in fact the CD4 T cells are the primary driver of disease. They're not the only thing that plays a role, but they're the primary driver of disease. And so that's why our approach really is to aggressively suppress the T cells. So we sort of take on the role. We assume they have no regulatory T cells that are functional. We take on the role of the regulatory T cells, and we use T cell-directed immune suppression, and we are very aggressive in dosing. We use tacrolimus, cyclosporin, and sirolimus. And And so that's really the core of the initial therapy for these patients. In addition, of course, to aggressive supportive care, aggressive care of skin disease, and in patients who've got high titer autoantibodies, which many of them do, we use rituximab. And we do all of this in preparation for being able to take them to bone marrow transplant. And so I want to just segue for just a quick minute to make sure that we're all on the same page, because I am going to talk about bone marrow transplant a bit as we talk about these diseases. And I want to make sure that for those of you who don't do transplant all of the time, just make sure as we talk about a few of the terms that we're on the same page. So when you talk about bone marrow transplant, there's a few things that you need to know that are really key. Number one is you need to know what the conditioning regimen is. How are you going to clear out the existing bone marrow to make space for the donor bone marrow that comes in? You need to know about the donor, and you need to know about the graft versus host disease prophylaxis that's going to be used in that regimen. And these is sort of the core of any bone marrow transplant regimen. When we talk about the conditioning, and I'm going to highlight this because this is going to come up again in the talk, you can do no conditioning, so give nothing to wipe out the bone marrow. This is really only done in the setting of severe combined immune deficiency, where they really don't have an immune system that can reject the donor cells. Okay, so that's sort of a novel case. For most patients, though, we use one of these types of conditioning regimens to deplete their own bone marrow, their own immune system, to get rid of it, so there's space for the donor cells to come in. Now, on the extreme end is myeloablative conditioning. This is where you go in and you just wipe out everything. If the donor cells don't take their own immune system, their own cells don't come back, they're acellular. Okay, so that's myeloablative conditioning. That's sort of on the extreme end. Now, there's a number of regimens that are called reduced intensity, where you use just less, and then a minimal intensity or a mini transplant regimen. And you can sort of think of these as sort of like, big gulps. So, you've got small, medium, large, or extra large. Anyway, in terms of the intensity of these. Now, you can imagine with the intensity, with an increase in intensity, there's an increased risk for side effects. There's an increased risk for infections and complications. Okay, so ideally, we want the transplant to be as safe as possible, but we also want to make sure that the donor cells can get in there and get in there permanently and make space and do their thing. So this is the conditioning regimen, and I'll come back to that. When we do the conditioning, the drugs that we use do two things. There's a group of drugs used in conditioning regimens that are myeloablative, so they just kill the cells in the bone marrow and the immune cells throughout the body. And then there are drugs that are used that are immunosuppressive. And we use those drugs to suppress the immune system so that they won't reject the donor cells that come in. Okay? So all of these conditioning regimens are a combination of these. Now, down here is no conditioning. Up here is fully myeloablative conditioning. This is sort of the classic busulfan, Cytoxan, ATG regimen. And then here's sort of the reduced intensity, the minimal intensity regimens here. And all of them, though, combine these drugs in a way to be able to do their thing. Now, as far as donors go, we like to use matched related donors. These are typically the best donors, siblings that are completely matched. That's the best chance of getting a graft and the least risk of rejection. And then, of course, matched unrelated donors, cord blood donors, and then either mismatched or haploidentical donors. Of course, as you get more and more mismatched from the recipient, between the recipient and the donor, there's an increased risk of graft versus host disease and graft rejection that goes along with this. All right, so with that in mind, so that little sort of background, get us all on the same page about bone marrow transplant. How do we transplant these patients with severe autoimmune disease? And we've thought a lot about this, and I think that it varies by disease, as I will mention. So for IPEX, one of the things that we know is we just need to get some regulatory T cells. If we can get some of those psychologists in there to regulate this immune system, that's all we need. So you don't actually need the whole immune system. And so it turns out that for these patients, you can do reduced intensity conditioning or even minimal intensity conditioning. And so we've got our approach in Seattle is that for patients who don't have too many comorbidities, we can sort of tune them up and get them healthy before we go to transplant, We use this regimen, which contains triosulfan, which is an analog of busulfan, fludarabine ATG. It's sort of a reduced intensity, reduced toxicity regimen, and we use bone marrow or peripheral blood stem cells, and this is where what we like to use the most. This is sort of, it's an aggressive reduced intensity regimen. It gets rid of all of those autoimmune cells that the patients have and allows space for the donor cells to get in. Now, some of the patients that come to us have really profound comorbidities. So invasive fungal disease, lungs that look like Swiss cheese, other things that are just make them extraordinarily high risk for transplant. Where if you used a very aggressive conditioning regimen, you would probably do them in. So in fact, most of these patients would not qualify for a more intensive conditioning regimen. So we've used a minimal intensity conditioning or mini transplant regimen where they just get a little bit of fludarabine, a little bit of total body irradiation, and then we use peripheral blood stem cells to just really drive in a graft. We can use a lot of donor cells. We can use that to drive a graft in. And we've used this approach. And this is generally the approach we've used for the patients. We've now transplanted 19 patients with IPEX in Seattle. And among these, there's 13 patients that we've transplanted on this regimen. We've had 1 graft rejection, 1 death on this arm. 5 patients on this regimen, 1 rejection and 1 death on this arm. And then we had 1 patient that had a fully myeloablative regimen who was really a salvage therapy. The patient was in terrible shape using cord blood donor, and he died early post-transplant. But with these 2 regimens, which are really our go-to regimens, the overall success has been very good, and these patients are clinically much, much better post-transplant. Now, if the pancreas, all of the islets have already been wiped out by the time you go to transplant, or the thyroid is wiped out, then they have to stay on insulin, they have to stay on thyroid hormone, but everything else resolves. And they're sort of left with whatever comorbidities they went into transplant with, which is why we like to transplant these patients early in the course of disease. So let me move on and talk about some of these other disorders, because I think it's informative, and I would suspect that you may have seen some of these patients floating around because they tend to show up in the GI clinic, they show up in the dermatology clinic, in the endocrinology clinic, because they've got those sorts of problems, as you'll see. So I'll use a couple of clinical vignettes. This is a 6-year-old who presents with arthritis, diagnosed with polyarticular JIA and treated by my mentor who trained me in pediatric rheumatology, David Sherry, for a long time as just a JIA patient. Then when she was 13, she developed cytopenias, particularly ITP, and then she subsequently developed autoimmune hemolytic anemia. She was noted to have splenomegaly at the time, and they thought, well, that's just because she's sequestering all these cells. That's part of her autoimmune cytopenias. And then at 21 years of age, she developed recurrent sinopulmonary infections, was noted to have low immunoglobulins, found to have B-cell lymphopenia, and then her cytopenias became very problematic, so much so that we had a hard time controlling them with traditional therapies, and we decided she's going to ultimately fail, and at age 27, we took her to bone marrow transplant, not knowing what her defect was, and just for lack of, we were concerned about her ability to survive long term. And she did great with bone marrow transplant. Subsequently, interestingly, her sister came to us as a young adult and said, I was diagnosed with multiple sclerosis a little while ago. It's been very resistant to therapy, but now I've developed recurrent infections and have B-cell problems and antibody problems. And then she had developed cytopenias, and we said, well, transplant worked for her sister, we'll transplant her. So we transplanted her as an adult. Again, still not knowing the defect. And she did great. And then we found the defect, and the defect turned out to be this disorder, which is CTLA-4 haploinsufficiency. And I'll explain what this is in a minute. So this was described initially in a paper from the NIH, and they found this in patients there who had been followed for in their ALPS cohort, large spleen, large lymph nodes. And these patients just have massive lymphoproliferation. They have lots of early onset autoimmunity, diarrhea, enteropathy. You see, respiratory infections. Cytopenias are really common in these patients. And this is a biopsy from the gut of one of these patients. Again, B cells surrounded by T cells. It looks kind of familiar, kind of like what we saw in the pancreas of that IPEX patient. And they get this in the gut, the lungs, the brain. That's the link to the MS in this patient's sister. It wasn't really MS, it was actually this disease, just lymphocytic infiltrates in the brain. And this is what CTLA-4 does. So this is so under normal circumstances, antigen-presenting cells activate T cells, and they require a few signals to be able to do this, because you don't want your T cells just like getting activated willy-nilly, or you develop severe autoimmune disease. And so the first signal that antigen-presenting cells provide to T cells is that they present antigen in the MHC molecules. Remember that the MHC molecules are kind of like a hot dog bun on a stick in the membrane of the antigen-presenting cell, and then the hot dog is like a little, the peptide is like a little cocktail weenie that sits in the hot dog bun, and then the T cells see that, and that with their T cell receptor. And so that is signal number one. Signal number two comes from these co-stimulatory molecules, CD80 and CD86, binding to CD28 on the T cell. Now, if the T cell only gets this signal, it gets interested, but it doesn't get activated, okay? It requires this second signal from this co-stimulatory molecule binding to CD28. The antigen-presenting cell then secretes a bunch of cytokine that gets the T cell really angry, and it starts to grow and divide and become activated. All right, now, activated T cells, and particularly regulatory T cells, express this molecule called CTLA-4 that acts like a stop signal to this process. And what it does is it actually binds to CD80 and CD86 in place of CD28. And what it does is it actually yanks them out of the membrane of the antigen-presenting cell, just rips them out. Okay? And so what it means is the antigen-presenting cell now can do this. It can show antigen, but it can't provide the second signal, and so it can't activate other T cells. So it turns down the immune response. And so in these patients who have CTLA-4 haploinsufficiency, what they've got is they have a mutation in one copy of CTLA-4, so they have only half as much CTLA-4 as they're supposed to have, and they then develop severe autoimmune disease because they have only half as much stop signal, and you need a full amount. And so these patients develop autoimmune disease. Now, what I'll say is that there just happens to be a drug on the market, already FDA approved, called Orencia or abatacept, which is CTLA-4 Ig, that is just CTLA-4 stuck to the tail of Ig. And so that's exactly what these patients need. And so you just give them that, and many of them do dramatically better. You just give them more CTLA-4 back. And so this is really, this is precision medicine at its best. So you find the defect, there's a specific drug that targets that specific molecule, you give it back, and it really makes them generally dramatically better. Now, some of the patients still fail therapy, and so some of them have to undergo bone marrow transplant. And so we have looked sort of at the world experience of bone marrow transplant. This was published a couple of years ago. We were able to identify 8 patients worldwide. There were 5 in Newcastle and 3 in Seattle is all that we were able to find. Transplant, essentially, it works for this disease. These were patients who were transplanted, and 6 of 8 were alive and well. These patients were transplanted, again, it's kind of like a last-ditch effort. So they were sick when they went to transplant. So we think that maybe if you take them to transplant early before they're so sick, outcomes may be even better. But this transplant works for this disease. It works for this disease. And this is another disorder that also affects CTLA-4. A couple of years ago, Mike Leonardo and Mike Jordan described that defects in this gene called LRBA, is actually required for the recycling of CTLA-4. As it gets internalized off the cell surface, it recycles it back out to the cell surface, keeping the levels on the surface high. And so these patients also have low CTLA-4. They do much better with abatacept, and they also do reasonably well with bone marrow transplant. This is a cohort that was collected by Marcus Seidel in Europe with the European experience. All right, so that gets us here. So those defects, again, have to do with this direct ability of Treg cells to suppress other immune cells through direct cell-cell interactions using CTLA-4, okay? Now, I want to go on and talk about these disorders next because I think they are also informative. So again, another patient vignette. This is a child that presented at 3 months of age with watery, foul-smelling stool beginning shortly after birth. He had failure to thrive. 5 months of age, he developed eczema. IPEX was ruled out by genetic testing. And at 18 months of age, he underwent bone marrow transplant using a reduced intensity conditioning regimen. He had a very complicated transplant course, and ultimately he rejected most of his donor graft. He retained 30% of his T cells, of the donor T cells. That's all he's got. Everything else was gone, okay? Now, he did a little bit better clinically until he was about 11 years old when he developed severe diarrhea again, up to 6 liters of stool out per day, and was completely TPN dependent. He also had developed recurrent ITP and some eczematous rash, and the family at the time was not interested in a second bone marrow transplant. And so the question is, what do you do with this? Well, first, again, we thought we got to find the genetic defect here. And so we did, and that defect turned out to be in STAT1. Now, what are these STAT proteins? These are a group of transcription factors that are super important. They play a major role in the intracellular signaling for a number of cytokines and growth factors. And STAT1 is particularly important for responses to interferons, okay? And so it's the key transcription factor responsible for signaling from, in response to interferons. And so the way that these work is the cytokine receptor is here. It has kinases that are bound to the receptor called JAK kinases. And when the cytokine binds to the receptor, these kinases phosphorylate the receptor on tyrosines. Now, the STAT proteins have a domain called an SH2 domain that binds to this phosphorylated tyrosine. These kinases then phosphorylate the STAT protein itself. They dimerize together through their SH2 domains, go to the nucleus, and turn gene transcription on and off. Okay, so that's their job. They're like switches to turn gene transcription on and off. And that's how they work. And as I mentioned, type 1 interferons, type 1, type 2s, act through STAT1. Now, this patient was found to have a gain of function mutation in STAT3, in STAT1. So these mutations, what we mean by gain of function is that they actually turn up the activity of STAT1, and that's shown here. So this is a flow cytometry plot. This is taking patient cells and looking at the amount of phosphorylated or activated STAT1 in those cells. And in green are cells that are not activated and where there's very little. Again, the increasing phosphorylation is denoted across this axis on the plot. There's no phosphorylation, and in a normal individual, you activate them here for 7.5, 15, and 30 minutes. Normal individual in blue, they become phosphorylated and activated. They get activated, and it settles down a little bit, but they stay activated for a long time. Whereas in a patient with one of these STAT1, with these gain of function mutations, they get hyperactivated. They get super activated. Note that this is a logarithmic scale. They get massively activated. It's as if you had taken their cells, and maybe treated if you didn't know better, you'd say, well, the one in blue just got a little bit of interferon. The one in red got a lot. Well, it turns out they each got the same dose. And the ones in red, though, act like they got a lot of interferon. Okay? And so they're hyperactivated. And these patients were originally described as having mucocutaneous candidiasis, chronic mucocutaneous candidiasis, thrush, candidal esophagitis, really bad, maybe skin candida, many of them. Subsequently, we found several of them who actually have developed severe autoimmune disease and can look just like IPEX, including a patient who was followed here at this institution for a long time. Actually, the first STAT1 gain of function patient with an IPEX-like phenotype that we found was from this institution who came for a consult, and he's subsequently been transplanted here and did well. So these patients, so here's the little guy that I showed you the clinical vignette. So his 6 liters of stool was back in here, and so tapering down, so here's tons of stool, and because we knew that his disease was caused by this gain of function mutation in STAT1, we thought, well, we just need to shut down STAT1. So how do you do that? Well, there's actually drugs on the market that are JAK inhibitors, JAK kinase inhibitors. You can shut down the JAK kinase. And by doing that, you can shut down their STAT activation. And so we put him on one of these JAK kinase inhibitors, and you see his stool output drops off. We adjusted the dose a little bit more, and within 10 days, so here at this point, he's completely TPN dependent, not able to take anything orally or he stools out. Within 10 days, He's off TPN, the line is out, and he's out the door. So again, and he'd been in the hospital for 6 weeks. So this is the power of finding the genetic defect, and we've got now all of these great drugs that we can use in a targeted way in these patients, okay? And so he's been on this drug now for about 2 years and is doing very well. Here's another patient, again, sort of perking along, not growing. We started him on one of these JAK inhibitors, and his growth spiked up, and he's growing again here. So that's the thing here. Now, we also have looked at the world experience at bone marrow transplant in these gain-of-function STAT mutations, and we in the STAT1 patients, we found 15 worldwide, and this one was really, I think, stark in that survival here was very poor. Only 6 of 15 of these patients survived transplant. And the thing that seemed to really jump out here was that 8 of the 15 patients that had been transplanted had graft rejection or graft failure, primary or secondary graft failure. And there is data in the literature to suggest that interferon gamma, high levels of interferon gamma, may drive graft rejection. Now, these patients don't have high levels of interferon gamma, but their cells act like they have high levels of interferon gamma. And our hypothesis is, we don't have any data yet to prove this, but our hypothesis is that maybe that's what's going on here. These patients are difficult to transplant, and so the STAT1 gain-of-function patients are a real challenge. There's also a disorder caused by STAT3 gain-of-function disease. We've also collected these patients. Lisa Forbes has been leading the charge on this one. And these patients, 16 worldwide, they've actually done much better than the STAT1 gain-of-function patients. And this paper is just about to be submitted to Blood. So getting back here, again, we talked about these defects that affect the ability of regulatory T cells to directly suppress through direct cell-cell interactions, other immune cells. These gain-of-function mutations that we think maybe the problem here is that the effector cells just get so revved up, so activated that you can't turn them off. And maybe the regulatory T cells are less reliable. And then lastly, I'll just show you just one case here, which has been informative in terms of IL-10 receptor deficiency. Again, regulatory T cells can use IL-10 to suppress surrounding cells. This is a patient that presented to us at 12 years of age, but he actually had really severe gut disease, a fistulating colitis that had begun in infancy, and he had really been very resistant to therapy. And here you can see his fistulating colitis, and he went to bone marrow transplant, and this is shortly after transplant. You get rid of all of these cells. Basically, the problem here is he has a defect in the IL-10 receptor. So his immune cells, he can make IL-10, but his immune cells are deaf. They can't hear IL-10. They can't hear that signal. They can't respond to it, and so they can't be suppressed. And so so you get rid of all those activated cells, you give him back a new one, and now post-transplant, he's done very, very well, and he's several years now post-transplant. And so again, that's taught us a lot about the ability of regulatory T cells to suppress here. So we've learned a lot about bone marrow transplant from these diseases, and I'll just summarize with this, that the bottom lines of this are that there's now a significant number of disorders, primary genetic disorders, that predispose you to autoimmunity. The roots of this, really among the first to recognize this and collect families, I want to just shout out to Anne Shigioka, because she really collected some of the initial families that highlighted these diseases, and I think to honor her today during this grand rounds. These specific genetic disorders are important. They're teaching us about basic mechanisms, that it's important to know the genetics, because if you know the genetics, you can personalize therapy. And lastly, that replacing the immune system by bone marrow transplant works better for some of these than others. And I just want to recognize all these folks in my lab, and of course collaborators and many others who've submitted patients. And I will end and be happy to take any questions. Thank you very much.
I think we can take one question. Anyone have a question?
I was wondering about the CTLA4 mutation that you found. Does it interfere with expression or with ligand binding?
One more time, I'm sorry, I didn't hear the last part of that.
The CTLA4 mutation that you found, does it interfere with expression or ligand binding?
Good question. So the question is, does the mutations that have been found interfere with expression of CTLA4 or ligand binding? So it's not entirely clear. So most of them, it appears, probably interfere with expression, actually. And so they get stuck in the Golgi, a lot of them, and they never make it out to the cell surface, it seems, for a lot of these mutations. And so we think that a lot of them have that effect. There are some that probably affect ligand binding as well, but the majority seem to maybe affect expression.
Roy, excellent talk, really superb. In the IPEX, you mentioned in one of your slides, it had neurological diseases along with it. Those autoimmune
Great question. So the question was, in the IPEX patients, I had listed neurologic diseases. So I should have broken that out more. So there's a number in there that so many of them had seizures, and a few of them have had, there's a couple of them have had actually structural abnormalities, hydrocephalus. We don't know whether that's autoimmune mediated. We don't know whether the seizures are autoimmune mediated. We haven't found antineuronal antibodies, things like that in these patients. And you know, the difficult part here is that these patients have pretty significant metabolic derangements when they're early in their disease. You know, they get, you know, diabetes, and so we think that some of the seizures may be related to either the glucose metabolic derangements or electrolytes, because, you know, they've got terrible diarrhea and they've got electrolyte imbalance. So we actually don't really know as much about the neurologic disease in these patients, but it's clearly there, and some of them there's developmental delay in a few, but we don't know whether that's primary or whether that is secondary to just being chronically ill and not exposed to sort of normal, you know, not able to go to school, a lot of them, things like that.
We should probably wrap up. Thank you so much. And thank you to the Shigeoka family and the foundation for supporting this lecture.